This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. And we want to talk a little bit about hearing aids, some of the issues associated with hearing. And we've got with us today Dr. William Even. He's the Director of Clinical Audiology at UT Southwestern Medical Center. Dr. Even, welcome to the show.
Thank you, and I really appreciate you having me on.
You know, just to set up this conversation, especially for our listeners, what does an audiologist do, and why is it important that we get our hearing checked?
So an audiologist is a licensed health professional. Most of us have a clinical doctorate. We work with the identification and or management of hearing and balance issues. I like to use the analogy of ophthalmology versus optometry. It's not a perfect analogy, but an ophthalmologist would be a medical doctor that can prescribe medications or perform procedures on eyes, and an optometrist would be the individual that does the testing on your eyes and can prescribe eyeglasses. We're probably a little more like optometrists. I'm not a medical doctor. And here at UT Southwestern, we perform a wide variety of testing and hearing loss management options for patients of all ages. And we're probably most famous for fitting hearing aids, which happens to be my clinical focus.
Which brings up a question. At what age would you recommend individuals have their hearing checked or tested?
There's probably not a hard and fast set rule for this. But one point I'd want to get across is it's not just about age. We see patients across all age groups. And I think sometimes people wait too long because they think I'm not old enough yet to get my hearing tested. You know, it might be good to, if you're getting up around that age of 50, 60, 70, at least get a baseline. But really, you might want to go more on the types of experiences you're having with your hearing. If you're starting to miss a few things, or you're having more trouble in restaurants and noisy groups, you're turning the TV up louder than your spouse, or sometimes patients with difficulties will start to report that their friends and family members are mumbling a lot, which can be true, but you'll start to notice a few of these issues, and might be something worth paying attention to.
You know, as you look at patients that do have hearing loss, what are some of the common things that impact your hearing and cause loss of hearing?
I just said to not stress the aging process, but the aging process is probably the biggest factor. And that tends to get to most of us at some point in life. But other things would be obviously noise exposure. So if you've had a history of military service or hunting, a lot of loud music. Today, people like to use headphones and turn those up pretty loud. Or often it's just a genetic factor. So some people tend to get hearing loss earlier in life, or they're more susceptible to noise exposure, and other people have what I would call tougher ears that are less susceptible.
You know, you brought up in your answer something very important. Hearing loss, can that be hereditary?
Oh, yeah, absolutely. Sometimes it's hereditary in the sense of a particular hereditary condition, or sometimes it just expresses itself in someone experiencing hearing loss younger in life for lesser known reasons, but it could be encapsulated in that hereditary bucket.
You know, sometimes, as you know, children have ear infections, and unfortunately, some tend to have recurring ear infections. If you have ear infections repeatedly at a young age, can that impact your hearing long term?
That's a good question. It can impact your hearing in the short term, and some of those kids will, in the short term, get a little behind due to the consequent hearing loss. The good news is that they tend to get up to the same speed as their classmates as they work through those issues, and in most cases, those are temporary issues that kids can grow out of or get treated for, and don't cause long-term problems later in life. Now, occasionally, there are some more severe cases where it can leave some damage to that hearing system that doesn't completely go away. But those are things that could be managed as well. I think that pediatric population, they're better at staying on top of these issues and managing them throughout childhood. I think adults are more likely to ignore things or not be aware that they have a problem.
You know, I hear many adults say, hey, I hear a little ringing in my ears. Oh, it's getting progressively worse. What is ringing in the ears, and what causes it?
Ringing in the ears can be caused by a wide variety of things. So I'm going to focus on the most common so we don't get lost in the weeds. The most common cause of ringing in the ears, in my opinion, would be hearing loss. So you could compare this to something like phantom limb syndrome. So if let's say you lost your arm from the elbow down, those patients may report pain in their hand. They don't have a hand, but they still have a nerve pathway leading from the elbow to the brain. So that nerve pathway can get a bit confused by the absence of information, and it results in some phantom pain. So you could think of that with hearing. If you're not hearing certain pitches, you still have a nerve pathway going from your ear to your brain that can also get confused by that absence of information, and you can hear some ringing, often at the frequency range of the hearing loss. So sometimes patients will think they can't hear a certain pitch because of their ringing, and it's actually the other way around. They have ringing because they can't hear that particular pitch. Now, that's part one of the answer. I would like to address part two, which involves the brain and our reactions to it a little bit more. The second part of the answer would be how we react to that sound. And patients react very differently to ringing in the ear from patient to patient. So some people are just simply not bothered by it. They notice it. They realize it's there. And for those patients, they tend to grow to the point where they notice it less and less. Other patients can become more disturbed by it. And the more you worry about it, the louder it can seem. And the louder it seems, the more you worry about it. And they can get caught up in a cycle like that. So one aspect of treating it would be to work on the hearing loss, and the other would be to work on the reaction to it. And we provide some good educational counseling here on ringing in the ears that can help a lot of people.
And it seems like so many people are talking about ringing in the ears these days. You're listening to The Human Side of Healthcare. This is Dr. William Even, who is the Director of Clinical Audiology at UT Southwestern Medical Center. So what about over-the-counter hearing aids? We'll talk about it next.
This is The Human Side of Healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're jumping right back into our conversation with Dr. William Even from UT Southwestern Medical Center, and today's topic, our hearing and hearing aids.
You've mentioned different reasons for hearing loss, and I know we have certainly not covered them all. But for people that see these advertisements on TV and these over-the-counter products, are they worthwhile? What are your thoughts?
I think that's a very hot topic, and you'll get very diverse opinions on it. And I'm trying to stay a little more in the middle because I see some dangers to it, but I also see some advantages. I think the danger to it would be thinking that solution can do more than it can do. It's limited to a very narrow prescription range. So it's only approved for mild to moderate perceived hearing losses. So first I would say, well, what is a perceived hearing loss, without a hearing test? So you may have a lot of patients with severe to profound hearing losses going out and getting over-the-counter hearing aids that really aren't going to be helpful for them. The second is that these devices have very limited degree of programming capability. So it's not something that you're going to get finely tuned to a prescriptive target. Maybe they'd be a little more like reader glasses that you get in a drugstore versus prescriptive lenses that you would get from your optometrist. The third concern would be you won't be getting any support in terms of teaching you how to use them, how to maintain them, kind of working you through the acclimation period of getting used to what you're hearing. It's going to be very different than what you heard before. So my concern would be if people are getting these and have a bad experience because it didn't help, and then kind of throw out the baby with the bathwater, when actually maybe they would be better candidates for prescriptive devices at a medical clinic.
Yeah, that's a great answer. And I loved your analogy to going to the pharmacy and buying a pair of readers as opposed to getting prescription glasses. Thanks for that distinction. So I'm going to kind of put you on the spot. With these over-the-counter products, are you seeing them impact your clinic?
I think a lot of clinics and people in my profession were pretty concerned about that for a while. I really wasn't. And so far, I know they haven't been out very long, it hasn't had any impact at all in our clinic. And I think that gets at these very different delivery models. So one delivery model is just simply taking something off the shelf, putting it on your ear, and it does what it does or doesn't do. And that's your outcome. I think most people need quite a bit more support. They have more difficult prescriptions to fit that require some skill and specialized equipment, and that's not going to go away.
I want to ask you another question. We've talked about kind of the aging process, heredity, and other things, but about 20 years ago, I had a really good friend, and he got really sick, and he was in the hospital, and they had to give him a medication, and it actually caused hearing loss. Does that occur sometimes?
It can occur sometimes. Receiving a medication and immediately having a drop in hearing is probably a little more rare. I don't hear of that very often. More common examples would be, things like chemotherapy can affect your hearing. Certain very strong antibiotic medications can cause some drop in hearing. Often the conditions those patients need that treatment for, it can't be helped. So the risk of hearing loss might just be something we have to deal with. But for the most part, I wouldn't say that's a real common occurrence on a day-to-day basis.
You're correct, and you answered the question. He had some large doses of antibiotics they had to give him, and it created that hearing loss. If you're experiencing hearing loss, what are some of the consequences of not getting it treated?
The most obvious would be that it creates a barrier to participation in daily activities and difficulty communicating in work and social environments. It can lead to a decrease in quality of life. But there's some interesting, what seem like some unrelated things that can occur as well. There's some associated issues like cognitive decline is starting to get a little more, depression, anxiety, increased risk of falls. That was another one that kind of surprised me when it was first coming out. And things like difficulty with employment.
You talked a lot about some of the consequences as you lose hearing. We talked about ringing in the ears. So I'm going to ask you, COVID-19, we've been dealing with it for 3 years. Have you seen any correlation between people with COVID-19, especially long COVID, and hearing loss, or even ringing in the ears?
So it's a bit of a dicey topic. We have seen more patients reporting ringing in the ears, whether it's directly caused by that or from the increased stress of the times is hard to differentiate. When I mentioned earlier that some patients are more bothered by their ringing in the ears than others, some of the factors that lead them to be more bothered can be things like increased depression, anxiety. Often there's a life event that may have occurred recently, maybe a death of a family member or an accident has occurred. So all of these kind of stressful things can lead to an increase in ringing in the ear. So the question is, did the condition cause the increase, or did the increased stress of the condition and current times cause it to increase?
You know, Dr. Even, when does someone really reach a point that triggers the thought, you know what, I may need a hearing aid?
Probably the most common one that comes up first is a patient will say, I'm not hearing as well in a restaurant or a noisier group setting. Now, everybody struggles more in that situation, but they may notice an increase in struggle in that situation. Another one I had mentioned earlier would be disagreements over television volume. That's a pretty common one that comes up. The reports of your family members, don't discount those. So a lot of times a spouse is the first one that brings it up to the person with hearing loss, even if they're not perceiving it initially. You might perceive your family and friends as mumbling. And in my case, that happens with my wife all the time because I think she does mumble. But when my hearing was better, I don't think it bothered me as much. So any of these things that might be occurring, just start out with getting a hearing test. And that doesn't mean you're jumping in to getting hearing aids immediately. So let's just find out what's going on, get it medically evaluated. No one's going to pressure you to get hearing aids just because you got the test, but you'll at least know what you're dealing with.
So to our listeners out there, do you have final thoughts or final advice to them related to testing your hearing, hearing aids, or any of the things that you deal with in your practice?
Yeah, and I think I'd probably want to talk less about the technical aspects. When this interview opportunity came up, I really liked the title of your show, The Human Side of Healthcare. And I think today, many areas within and outside of healthcare, the pace of the world is increasing, and personal human relationships seem to be lessening quite a bit, or at least that's my perception. And I think of us all as patients with whatever we're dealing with. So, you know, if you're going to purchase some windows at a home supply store, or you're ordering food at a restaurant, or you need a technical support assistance on a phone call, I get frustrated when I see any type of professional, and it seems like they're not really listening to my concerns or my questions, and just kind of going on autopilot. And I think that's where some of those that human side of healthcare can be decreasing, especially as people get busier. So my goal when I see a patient is, no matter how stressed out I am or how short on time, I don't want my patient to perceive that. You should feel like you're the number one focus and concern during our time together. And over time, I think it's actually very common in our field that we develop friendships because we keep seeing each other over many years. So my final thought, and this is my advice, is that at least in our field, you should feel really close and comfortable with your audiologist. You're going to have an ongoing relationship, and bedside manner is really important. And you need to trust that they have sufficient skills and that they have your best interest at heart. So I would just say, they should look you in the eye. They should listen to your concerns. You should never feel like a sales target, never feel like a nuisance for taking up too much time to get the best result possible.
This has been Dr. William Even, the Director of Clinical Audiology at UT Southwestern Medical Center. Now, there is a test that you can get on a CT that can tell you the condition of your heart and if you might be prone to a heart attack. We'll tell you about it next.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the human side of healthcare. Delighted you're with us today. We want to talk a little bit about heart imaging and some of the diagnostic tests that physicians use related to diagnosing heart problems or treatment that needs to be done. We're very fortunate that we've got with us today Dr. Vinit who is the medical director for Interventional Cardiology at Medical City North Hills Hospital. Welcome to the show.
Thank you, and I'm glad to be here.
You know, there are so many tests that are available when you think in terms of diagnosing heart conditions. I'm just going to throw a term out and see your response. What is a CT angiogram?
CT angiogram is taking pictures of the blood vessels by injecting a dye and taking the picture through a CAT scan machine. What we do for heart, it's called CCTA, which is the CT angiogram, but we do for the blood vessels of the heart, which are coronary arteries. So the correct term for heart would be cardiac CTA or coronary CTA.
So when you think in terms of a cardiology standpoint, you mentioned the CCTA angiogram. What is it used to help diagnose in cardiovascular issues?
The most common reason to do this test is to check for blockages in the blood vessels of the heart. And this is a non-invasive way, so you do not have to go to a cath lab and have tubes inserted in your body, but you go to a radiology place, get an IV, and then a CAT scan machine will take pictures. But besides looking for blockages, this test also gives very good images of various heart structures. And if somebody has a tumor in the heart or blood clots. So it's used mainly to get blockages, but it gets a lot more information on other structures of the heart, which some of these cannot be tested well through other imaging modalities which we use in the office.
There are many different types of tests for the heart. So under the answer you just gave, let's assume you run this test and you determine a blockage. Would you have to do other tests, or does this replace some of the work you normally would do?
So this test, if you're looking for blockage, will replace the stress test. But once you find the blockage, you will have to go through the invasive procedure to fix the blockage by doing angioplasty or putting stent in. Because this is a CAT scan procedure, you cannot fix a problem. This is a diagnostic test. But it will replace a stress test, but may lead to more procedures downstream.
You know, you brought up an interesting point that this could replace having to do a stress test. So from an accuracy point of view, how would this compare to, say, other tests that you would run, like a stress test?
In terms of accuracy, this is going to be a little more accurate than a stress test. A nuclear stress test, which probably is better than other kinds of stress tests, has around 90% accuracy, whereas a CCTA would be around 95% accuracy.
Does the CCTA involve radiation exposure?
It unfortunately does involve radiation, just like getting a chest X-ray or any imaging of the heart or body. Radiation exposure is there. You do not get radiation exposure in MRI. You do not get radiation exposure in ultrasound. But CCTA will involve radiation exposure, although this also has been going down compared to 10 years ago by new technology and new modalities. And it is probably between 30% to 40% of what it used to be 10 years ago.
You know, in your answer, you mentioned how this is such a more accurate test. Would you say that as we look to the future, it'll be enhanced and even become more effective?
Absolutely. Over the years already, this has been now moving more into a first-line test. In fact, the American College of Cardiology and American Heart Association, they have a guidelines. They come out every few years. And the most recent guidelines for chest pain, which they published last year, clearly offers the CCTA as a first-line test in many patient population, which is different from what the conventional thought was 5 or 10 years ago, where we would not do it very often.
You're listening to The Human Side of Healthcare, and we are talking to Dr. Vinit Lal, the Medical Director for Interventional Cardiology at Medical City North Hills. And we're talking about this heart diagnostic test called the CT angiogram, a test that can save lives. Dr. Lal, could you tell us what the test is like? Walk us through like you're describing it on the radio to somebody like they used to do the baseball games. Remember when they would narrate the baseball games from a teletype? Tell us as though cameras didn't exist. How does this test work?
So the way this test works, if you've never had a CAT scan, is you will go to a radiology place, and it can be in a hospital radiology department, or there are some private radiology practices who offer these kind of tests. And in fact, some cardiology offices do too. And they will start an IV, and through that, they will inject contrast material. They will monitor your heart, just like putting those EKG monitors. And then the table moves and gets you through the CAT scanner, and that's when they're taking the images of the heart while the contrast is flowing through your blood vessels. And what it does is it shows the blood flow in the blood vessels of the heart and also shows all the structure of the heart. You're done in maybe 10 minutes. You go home and you review the report with your cardiologist.
So I've had this twice, and when I had it both times, actually, there was a baseline. So you go in, the CT takes a baseline scan, and then they say, okay, now you're going to feel warm for a second. The dye comes in, you go right back in, the test is done. Next thing you know, they're getting you dressed. They're pulling that IV out, and you're ready to go home. Is that about still how they're doing it?
That's exactly how it is. So the first scan you get, it's almost like a CAT scan without any contrast. And then they give a IV contrast, which feels like a warm sensation inside your body. And that's the second CAT scan is with the contrast flowing, and it gives pictures of the blood vessels.
When I had my first one done, it was actually, I was the patient, but we were doing a promotional video for a cardiology practice that had a CT angiogram setup. And the results were back on the cardiologist's monitor within, by the time we could get back there. Now, I know you don't meet right with the patients typically, but it is that quick, I guess, to get the results.
Oh, results are there pretty quick. But what has happened is over the years, there are very, very few cardiology offices who do this test in their office. And obviously the biggest factor is the cost issue, because it's an expensive scanner, and then you need employees who can do this. So if I have to look around, I would probably say there are maybe 2 or 3 big practices who have their own CAT scanner, and most people otherwise would get it done in a radiology office or a hospital X-ray department radiology.
And then the results are delivered to the doctor, and you make an appointment, you go back. Now, can you describe for people the, to me, really cool 3D image of the heart that is created from this test?
Yes, so the images are unbelievably good in terms of getting 2D images and then 3D images. And as a cardiologist, we can rotate those images and look at all these structures from different angle. You actually see the blood vessels fill up, and you can see in the 3D image if there is a 30, 40, 50, 60% blockage. And, besides the blockage part, as I mentioned, in certain conditions like atrial fibrillation, you're looking at some structures of the heart. Some people have tumors of the heart. Sometimes some people have blood clots in the heart. In fact, in Europe, this test has replaced a different imaging done to look at blood clot in the heart. It's called TEE. And in Europe, they actually do a CCTA in all those patients because of a better quality of images.
So here you're able to look at, I guess, the valves, correct? See if the valves are functioning correctly?
Yeah, you look at the valves, you look at the coronary arteries, which is how people get heart attacks. So you look at blockages in that, and you see whether the valves are leaky or narrow. And you also look at tumors and other things. The only thing is for valves itself, you don't actually need to go through this CCTA because of radiation exposure. A regular echocardiogram, which is the ultrasound of the heart, it gives equally good pictures of the heart valve.
We are talking about a diagnostic test that could save a life, the CT angiogram, with Dr. Vinit Lal from Medical City North Hills. When we come back, we're going to continue this exploration of risk versus benefit when the human side of healthcare returns.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're exploring a heart diagnostic test that can literally save lives. But as with all radiation, it may have trade-offs. Our guest is Dr. Vinit Lal, the Medical Director for Interventional Cardiology at Medical City North Hills. Dr. Lal, in our last segment, you mentioned the radiation. Does that come from the CT or the dye or both?
It's in the CT.
That's just from the CT.
This dye has no radiation, yes. The CAT scan, it's almost like taking 400 chest x-rays.
Whoa. Wow. I was going to ask, so I just got my teeth cleaned the other day, and they took x-rays. How would the CCTA compare to what the dentist did? Quite a bit more, it sounds like.
This CCTA will mean that they took 400 x-rays.
Wow. Is that safe?
It is safe, but obviously that has always been the concern. That's why it never became a first-line thing in the past. And this is of more concern to younger women because the way the dose calculation is done, what the data suggested that if you expose, say, a 25-year-old woman to a CCTA, there's a chance that 1 in 150 may develop breast cancer in future because you're getting so much radiation, which in women obviously, going to go through the breast tissue, and that's a sensitive tissue in terms of future cancer development. But as I mentioned, that over time, what has happened with the technology and how they create the data, the radiation dose has gone down substantially. But any test you do for heart, like a nuclear stress test, also has radiation exposure. Get a heart catheterization, that also has a radiation exposure. But if you go through CCTA and you find a problem, so now you're going to be exposed twice.
Is the catheter procedure radiation, is that because it is a guided procedure? In other words, you're looking at an X-ray image to guide the tools into the heart?
Yes. You're looking, there's a radiation given from under the table. It's the same IV contrast which is used in CCTA. We do that in the cardiac cath lab. So you inject the dye to fill up the blood vessel, and then now you have to take pictures. And the only way you do it is like running an X-ray. So in the cath lab, it is the same concept. It's not a CAT scan, but you still have to give x-rays to take pictures as the dye flows through the blood vessel. And that's how you look at the circulation and blockages.
Okay, good points. So here's the bottom line of that, I guess, that we have to process. I'm a 63-year-old man. Obviously, when you reach that age, things can go wrong with your heart. And often the first time that you are aware of heart disease is from death, as they say. So what's the greater risk? Not knowing, or this exposure of radiation every 5 or 10 years?
I mean, that's the excellent point, which, is unfortunately the first symptoms of heart disease many times is going to be death. And getting this scan is very useful. But if you are able to get a stress test, now there is a different kind of stress test called stress echocardiogram, where you do not have any radiation exposure. In many patients, that probably can be the first line test rather than putting them through radiation. So there is a concept in cardiology and in medicine, it's called the pre-test probability. So if someone comes to my office and when I get all the tests from them, like EKG, hear the complaint, see the family history, and in my mind, I already think there is a good 70, 80% chance that this person may have blockage. I think doing CCTA, I'm going to add more radiation, cost, and contrast exposure. These are the patients you may want to just directly think of maybe doing a heart cath, because that's actually, in terms of accuracy, that's a 100% accurate test compared to CCTA. CCTA, the other downfall for CCTA somewhat is that in very big people or people who have a lot of plaque or calcification, so if they have kidney issues, they are diabetic, or if they had previous stents, CCTA's accuracy drops quite a bit because the X-ray cannot go through stents and calcification very well.
We know that heart disease is still the number one killer in the United States. So it affects a lot of people, a lot of families. With the tools that you just mentioned, from regular stress tests or go down the list of everything you just mentioned, is there a good reason for anybody to die from a heart attack if they are following up with this regularly and getting their heart checked?
The thing about heart attack is like this. This test will find the blockage if it's greater than 70% or so. Nobody fails a stress test if you have a 40, 50% blockage. And CCTA will show you if you have a 70, 80% blockage or a 30%. If you have a 30% blockage, you do not do anything to it, like stent or angioplasty, and definitely not bypass. Unfortunately, what happens is heart attack, 50% of heart attack is caused by blockages which are less than 50%. So heart attack is never a condition where you progressively develop 70, 80, 90, 99, and then you develop 100% blockage. Heart attack happens in even a 30, 40% blockage can cause heart attack. And that's exactly the reason why you may have heard of a lot of people saying, I passed all my stress tests and I had everything, and still ended up having heart attack 6 months later, because it's kind of a little different concept of having a heart attack. But you're right. I mean, we have so many good tests. Unfortunately, in cardiology world, there is no guideline like we have for cancer prevention and testing, like colonoscopy, mammograms. Heart disease kills more patients, more people than all cancer combined. I mean, you take all the cancers, and you see the people dying from that versus heart, you still have heart disease is the number one killer. But there is no generalized guideline where it says, well, once you are 50, even if not CCTA, you should go get a stress test, every 5 years or, 2 years, depending on, what you see. And I think that probably, down the road needs to be looked into by societies and government. Do we just sit and not do anything till somebody has symptoms? which could be the major heart attack, or try to work on prevention by using these kind of non-invasive modalities, which can give you so much information and help treat better, risk factor modifications, and take medication. So it's an excellent point you raised.
Let's say that a patient might not have enough symptoms to justify insurance coverage or Medicare coverage for a test like a stress test or even the CCTA. But they come to you and they say, I want to know, and I happen to have the money to be able to pay for it. Is that a wise thing to do, to say, I still want to peek under the hood?
Absolutely. The only reason we have to get insurance approval is if we are looking at them as a payer. People go to Cooper Clinic in Dallas and get all this tests. They pay $1,500, $2,000. They do like an executive kind of test. And you run through all that and you don't even submit anything to insurance. But if you want insurance to cover, you come to cardiology office, there is always a reason, and shortness of breath is always a reason to get a stress test. So you cannot always wait for symptoms. So you got to look at the total picture that, what are my risk factors? That's the number one thing, right? So if it runs in your family, there's a good chance this thing is, genetically, you are at higher risk. So getting a test with insurance paying, or, worst case scenario, I don't think anyone would charge you more than, $200, $300 to do a stress test, but you may want to just pay and get it done.
Dr. Vinit Lal, the Medical Director for Interventional Cardiology at Medical City North Hills, with what may be some excellent information to process about your heart. Steve?
Thanks, Thomas. Enjoyed the show. Please join us next week for the human side of healthcare.